Hey again, Dr. Mashburn. So today we're going to talk about leukocytes and platelets, continuing our talk about the blood. So, here we go. So what are leukocytes? Leukocytes are the white blood cells, okay, so WBCs. And they make up less than 1% of your total blood volume. You have between 4,800 and about 11,000 white blood cells in a microliter of blood. That will be normal. And that's important because if you have too little or too much, that may be a sign that something's going on. And we'll talk about possible reasons for having changes in white blood cell count. White blood cells, their main function is to fight against disease. They can actually leave your capillaries, your small blood vessels, via something called diapedesis, which means they can loosely kind of walk through the capillary bed. And once they get into the tissues, they can crawl through the tissue kind of like an amoeba. And they do that by following a chemical signal. So there are cells, and I'm going to show you this diagram here in just a second, that release chemicals that kind of are signals to your white blood cells to follow. It's kind of like a bloodhound following a trail. So you have cells that release chemicals, and then your white blood cells can follow that trail to the area of inflammation and then help fight the disease. So if you have a lot of white blood cells, if for some reason you do have an increased number above 11,000, we call that leukocytosis, and that's just a normal response to an inflammation. So what I'm showing here is we've been impaled by a splinter, and everything in the world is covered with bacteria, and so that's going to introduce bacteria into your skin. And so we see here we've broken the epidermis and into the dermis. Remember that from your first anatomy. And in your dermis you have cells that are just kind of waiting there to help protect your body, like macrophages, the big eaters that can go in and eat up and take care of things that need to be destroyed, and mast cells. Mast cells make histamine, so they're the ones that you react to if you're itching, so allergies, so you take an antihistamine. So as these bacteria are entered into your dermis, the macrophages and the mast cells are going to release chemicals. And so these chemicals are going to cause the capillary bed, you can say it has expanded or dilated, which is, it's also going to kind of open up and kind of allow the capillary to become leaky. And so that allows fluid, part of the plasma, the liquid part of the plasma to enter into this the dermis, and allows those white blood cells to leave and get into the dermis. So with the first signs of an infection or inflammation, you're going to see redness, which is that increased blood flow to the area. So that redness is what you see. Maybe heat associated with it. Swelling as that fluid leaves and fills the area. And also maybe some itching if your mast cells are causing you to release histamine. And then white blood cells are going to go out into the area, and they're going to phagocytose the bacteria. So they're just going to eat it up and break it down. So you may see, depending on how many white blood cells, you actually may see if it's a really big infection, you may see pus. So what you're seeing with pus is just those spent white blood cells that have come to the area to clear out an infection. So you have 5 different types of white blood cells, and they're divided into 2 groups called the granulocytes and the agranulocytes. So with granules and no granules. And the granules are just kind of packages inside the cells. So these have these little packages that contain different chemicals that are used to fight off infection. So like if you're eating the bacteria, you need to break up and dissolve the bacteria, those granules are going to have what you need to get rid of it. And so when you're looking at a microscope slide of blood, you'll see your red blood cells, these light pink discs, and then you're going to see in the granulocytes, you're going to see one that's kind of lavender, one that's more red, and one that's real purple. And the lavender one are the neutrophils, the red ones are the eosinophils, and the purple ones are the basophils. And I'll give you more details on those in just a second. The agranulocytes, they don't have those granules, and so I say the granulocytes look bumpy. Okay, and the agranulocytes look more smooth. And your agranulocytes are your lymphocytes and your monocytes. Okay, so what I want to get off this slide is a relative proportion of these cells in relation to each other. And you can use this nice little mnemonic, never let monkeys eat bananas. And so this is the most to the least. Okay, so you have the most neutrophils, never, then lymphocytes, let, then monocytes, monkeys, eosinophils, eat, bananas. Okay, and so that's important when you do a differential blood cell count, where you're measuring how many of these cells that you see in a blood smear. You wouldn't expect to see a lot of eosinophils. They're kind of hard to find, or basophils, either one. But if you were to find an increased number, that would be a warning sign that your body was fighting off some particular type of infection. And we'll talk about that as we move forward today. So remember, when you spin down a blood, you're going to spin out the erythrocytes, the leukocytes, and the platelets. That's kind of the formed, that's the formed elements that you're going to see inside of blood. And of those leukocytes, you have your monocytes and your lymphocytes, which are your agranulocytes, and then you have your granulocytes. Okay, that just kind of gives you another way of visually seeing the numbers of these cells in relation to each other. Okay, and that's pretty. I wanted to say one more thing as we would talk about differential blood cell count. Used to, you would take someone's blood and put it on a slide, and you would look in the microscope, and you would have this little funny little finger clicker, and you would count as you were counting neutrophils and basophils and eosinophils and monocytes. You would just be clicking and getting this count. I think now they have those things are kind of automatic, but back in the good old days, you would actually do a blood cell count. So that was always kind of fun to do that. I don't know that they even do that anymore. So just like red blood cells, they have to go through some kind of formation, and so we call that leukopoiesis. Okay, so leukocyte formation is leukopoiesis. Okay, just like erythropoiesis. So hematopoiesis is blood, all of the blood. Erythropoiesis is red blood cell formation, and leukopoiesis is white blood cell formation. So remember, you have your stem cell, and so it's going to be committed to either become a myeloid or a lymphoid cell. Now, I really am not all that interested in you knowing all of these middle steps, okay? But I do want you to know that the lymphoid cells are going to become your lymphocytes and your monocytes, okay? Your lymphocytes can be further differentiated into T and B lymphocytes, okay? And these T cells, some of them are going to become effector T cells, and this is going to become important when we get to immunity. And some of those B cells are going to become plasma cells, and some of those monocytes become macrophages. So remember those macrophages we've been talking about? They're like specialized monocytes, okay? The myeloid line, once they commit to the myeloid line, they will become either eosinophils, basophils, or neutrophils. Now, remember with the red blood cells, we talked about reticulocytes. The last stage of formation before they become mature eosinophils, basophils, and neutrophils is they go through what's called the band stage. And so sometimes you'll see people talk about segs and bands or polys and bands. And what they're talking about are these immature versions of these cells that have been released before they're fully mature. So that's where that term comes from. And again, that can be indicative of something maybe going on in your body if you're releasing a lot of reticulocytes or band cells. So again, your granulocytes, they're large. They're about twice the size of red blood cells, but they don't live very long. They're pretty quick, short-lived. They have lobed nuclei, and so sometimes you'll hear them called polymorphonuclear so polymorpho, having a multi-shaped nucleus. They have these cytoplasmic granules that stain, and so the neutrophils, they stain neutrally, so it's kind of a light purple color. The eosinophils, they take up the acidic part of the dye, and they look more red. And the basophils take up the more alkaline part of the dye, and they look more purple. So the first thing you can do is kind of look at their color. Then you also will look at their nucleus shape, and we'll talk about that, and how their granules stain. That kind of gives you an idea of what they are. We'll show you some more details in just a second. They're all phagocytic, so they all will go out and can eat things. So if you don't remember what phagocytosis is, I've said the word several times, but just to make sure that you remember what that means, is that's when a cell can take in a particle. So it's going to basically send its plasma membrane out. So it's going to chemotax and go, so crawl out and go to the particle, and it's going to ingest the phagocyte by sending the plasma membrane around it and basically forming a bubble or a phagosome. And then remember those granules I talked about? They're going to have some kind of digestive enzymes associated with those. Those digestive enzymes will fuse with those phagosomes, releasing those digestive enzymes. Those digestion enzymes will then break down the particle, and then that whatever the waste material, it will just be released back out into the body. All right, so that's phagocytosis. So we'll do a little bit again when we do the lab portion, but I'm also going to talk to you now, so hopefully you'll see it twice and it'll help you learn it for your lab portion. The neutrophils are the most numerous. Never let monkeys eat bananas. They're called polys or polymorphonuclear leukocytes because they have, it looks like it's several nuclei, but it's just poly means many and morpho means shape, so many shaped nucleus. So there's not really a certain nuclear shape that it has. It just looks like it's got, random different looking shaped nuclei. Boy, that made sense. So polys or PMNs, and you may hear people that are in the know say that instead of saying neutrophil, they may say polys. Again, they stain kind of a lilac color. They have hydrolytic enzymes and other antimicrobial proteins. So I call these the bacteria slayers. They're phagocytic, and so when you ever have bacteria, they're going to be your defenders that come out to eat the bacteria. All right? Those are your neutrophils. The eosinophils, they're the red staining. They take up the acid part of the dye, and they have a bilobed nucleus. It looks like a dumbbell. But it's one nucleus. It's connected, but it's bilobed. They also have granules that have these lysosomes, these enzymes, and their enzymes are for parasites. Okay, so most of us don't live in an area where there's parasites, but if you live in portions of Southeast Asia and Africa and South America where they have different types of worms, then you may have a high eosinophil count. When we typically see people with high eosinophil counts, a lot of times you can say, have you traveled recently? They say, yeah, I was on a mission trip, or I went down to South America. Did you drink the water, or something like that? So they may have been exposed to some type of a parasite. So when you were doing that old-fashioned CBC count and you saw an increased eosinophil count, then you go, okay, it's not a bacterial infection. This person has an eosinophil, has a parasite infection. But if they haven't traveled and they have high eosinophils, you may also ask, is their nose running? Are they having trouble breathing? Are they sneezing a lot? Because eosinophils also increase during allergy season. So people with just increased allergies also have high eosinophil counts. So if it's the spring, with all the pollen, or the fall with the ragweed, you may also see eosinophils. So you can't look at the number of eosinophils and go, oh, it's a parasite, or oh, it's an allergy. You've got to ask the question to the patient, where have you been? What have you been around? So that you can figure out what the problem is. Okay? Basophils are very rare. Never let monkeys eat bananas. So you should not see very many of these. They have a dark, deep purple nucleus. And they're almost really hard to see the nucleus, so I usually don't really even look for the nuclear shape, because their granules stain so darkly it almost occludes and hides the nucleus. It looks like a bumpy blueberry. So if you see something that's real bumpy and really dark purple, that's a basophil. And these will also contain histamine, and histamine is that inflammatory chemical that acts as a vasodilator, causes those vessels to open up, causes white blood cells to be drawn to the area. So they act a whole lot like mast cells. Okay, so very similar to mast cells. So you're going to have those come into an area when you've got like an allergic reaction, something's causing you to itch. So again, just as a reminder, that inflammation. Okay, inflammation is that increase in blood to the area, that vasodilation. So you're going to have redness, you're going to have heat, you're going to have swelling. That's inflammation, okay? And the reason you get the inflammation is because those macrophages and those mast cells release those chemicals, causing the capillary bed to vasodilate, increase blood flow to the area. Fluid can then leak out. White blood cells can diapedese and crawl out, and they're going to be drawn to those bacteria so they can phagocytize them and get rid of them. Okay, so that's basically what's going on in inflammation. Again, if you have too many of these and it's an ongoing problem and lots of more white blood cells and it starts to abscess and become pus-filled, then you may need to take an antibiotic. It's really maybe gotten beyond what your body can take care of. All right, so the A granulocytes, they don't have those granules, they don't look bumpy. They either have a spherical or round nucleus or a kidney-shaped nucleus. So the lymphocytes, they have a perfectly round nucleus, and the monocytes is kind of a kidney-shaped nucleus. All right, so we're going to go through each one of these. The lymphocytes are the second most numerous, never let monkeys, large purple nuclei. They have a really thin rim of blue cytoplasm. And so people often confuse the lymphocytes and the basophils. The lymphocytes, let me go back, are almost the same size as red blood cells. So if you see these cells, they're the same size as red blood cell, but you can see that there's some cytoplasm around it. You just look for that thin blue clear cytoplasm. That's a lymphocyte. The monocytes are about 2 times bigger than the red blood cells. They're huge. They're bigger than the neutrophils, basophils, and eosinophils even. So big with a large blue cytoplasm and a big kidney-shaped nucleus. So they're kind of hard to miss. Lymphocytes, hence the name, are going to be found in lymphoid tissue. Okay, so you're going to find them in the lymph nodes, in the spleen, and there's going to be some in your blood. So you'll see them, obviously, never let monkeys. There's a lot in your blood, but there's a lot in your lymph nodes and your spleen, and they are crucial to immunity. Okay, when we talk about the immune system, we're going to talk about these T cells and B cells. Okay, so T lymphocytes become T cells, B cells become, or B lymphocytes are B cells. The T cells, they act against virus-infected cells and tumor cells. I call them, they're called the immune system conductors. They recognize things that are foreign. They recognize what is self and what is foreign, and then they kind of alert, kind of pull the fire alarm and say, okay, there's something going on. We need to mount some kind of an immune response. Again, we're going to go into more detail on that later. The B lymphocytes, okay, once there's been an immune response initiated, we want to send out antibodies to kind of help get rid of this problem. They're going to be the ones that make the antibodies. So again, don't worry too much now. I'll give you more detail in the immunity lecture. The monocytes are the large ones. They have a big cytoplasm, big U or kidney-shaped nucleus. When they leave circulation, so the monocytes in the blood, but when they leave, they become macrophages. Okay, so they're phagocytic. We use them against viruses and bacteria and chronic infections. And they help activate those lymphocytes in immunity. So they help pull that fire alarm to get us started with an immune response as well. Again, more details coming about that. This is just a cool picture. This shows what a macrophage looks like. So it has, this macrophage has developed from a monocyte because it's left the blood. And so this is the cell. It's got these, what they call pseudopods, and so like fake feet. Pseudo means fake feet. And these are bacteria, so they're reaching out and grabbing these bacteria and kind of munching them up and taking care of that. So just a neat picture that I thought you might want to see what they really look like. All right, so leukocyte disorders, leukopenia, that means an abnormally low white blood cell count. That can be drug-induced. Different drugs can cause you to become leukopenic. And we'll have a few more things about this as we move forward in the semester. Leukemias, these are overproductions of white blood cells, and these are always cancers, and they're always fatal if they're left untreated. Okay, so there's many different types of leukemias, and it's an overproduction of these white blood cells. And you give the leukemia the name based on which cell is overgrowing. So you have myeloid leukemias, like these are from the myeloblast descendants, and so lymphocytic leukemias or the lymphocytes. So you may have heard someone that had a myeloid leukemia or lymphoid leukemia, and so it's either that, remember the stem cell goes myeloid or lymphoid, so that's where that's coming from. So which one of these cell lines has become cancerous? The two other terms that we use to describe cancers are either acute or chronic, and so acute leukemia are things that are usually stem cells. You're getting a lot of cancer cells being grown, and these are mostly in children, and they're quick, they're fast growing, and the symptoms show up pretty quickly, and they can be fatal fairly quickly unless they're treated. Chronic leukemias show up in older people, and sometimes they can occur at some of these stages down here. They don't necessarily have to be that stem cell. So you have an overproduction, but not necessarily, too much. It can kind of be controlled. You'll see them in older people, and people can live with chronic leukemia for years and years and years. So it kind of depends on how old you are and what the particular line is. Again, we tend to think of those acute childhood leukemias as being the more dangerous. But that's not to say chronic leukemia is not fatal. It is. It just takes longer. The problem with leukemias is that you get all of this overproduction of white blood cells, and it crowds out the bone marrow, and so it crowds out the other line. So if whatever cell you've got a bunch of, it makes it harder for the other cells to even be produced, and so you're going to get anemia, you're going to get bleeding, so you don't have infections, you don't have enough of the other cells that fight off infection, you don't have enough red blood cells to carry oxygen, you're going to be fatigued. So that's the problem. You also get a bunch of these immature, non-functional white blood cells in your bloodstream. So you have a lot of white blood cells, leukemia, a lot of white blood cells, but they're not functional. They don't really do anything. A lot of times with leukemias, you die of hemorrhage because you don't have enough platelets available. You may die of infection. So the treatments for leukemia, they usually use radiation or radiation therapy or chemotherapy, or bone marrow transplants for leukemia patients. Okay. All right, so the last thing are the platelets. I know this is getting a little long, I apologize. Platelets are your blood clotting cells, and so they have granules, just like the neutrophils, the eosinophils, and basophils, the granulocytes. But their granules contain things that are needed for blood clotting. Okay, so not for infection, but for blood clotting. So they have the first steps that you need to get blood to clot when you cut yourself. And typically you should find between 1 and 400,000 platelets per milliliter of blood. And they're able to make a temporary plug and help seal breaks in vessels. And we're going to talk more about blood clotting later on, but right now just know that they're essential for blood clotting. And so if you have leukemia, a lot of times what you'll notice is they have bruising because they don't have enough platelets, and so you have blood vessels. If you just hit your hand against the table, you may just notice a small bruise, but if you don't have platelets, it's going to be a very large bruise. And sometimes bruising is actually one of the first things that you notice on a child with leukemia. They just barely hit something, and the next thing you know, they have a really big bruise. And they're lacking those platelets because the white blood cells have overtaken and outgrown the platelets, and they don't have enough of them. There is a hormone, just like erythropoietin causes you to get red blood cells. There's something called thrombopoietin, which causes you to increase your production of platelets. Platelets are not they don't last very long. They only last about 10 days because they're parts. They're just little pieces. And so the way you get platelets is you have that stem cell again, and it starts to go down a committed pathway, and it becomes something called a megakaryocyte, and then it breaks up. And so what's actually floating around in your blood are these little bitty pieces of these cells, and these are the things that allow you to have blood clotting. And again, we'll have more detail on that later on. All right, that's it. So we'll see you in the next video. Thank you very much.